All right, guys, this is chapter 48, moving and positioning clients, or better known as ergonomics. All right, so nurses and aides, we get injured all the time. Usually it's a back injury of some kind. Because we tend to do things either alone that we shouldn't be doing or not using the right kind of assistance, whether it's some kind of a device or another person. So I did look this up on OSHA's website, and they recommend mechanical lift assistance as long as the clinicians are trained in how to use it and it's used properly according to the manufacturer directions. So yes, there are different types of lifts that you can use. Back in the day, we used to deadlift people all the time. I don't recommend it. I've got a lot of friends that have some serious back injuries because of it. So don't do anything that's going to put you at risk because frankly, the employers don't care about you. So we'll keep it real. Okay. And using the correct body mechanics is important, so we're going to go over what that means. Okay. So, and using the correct body mechanics also helps, number one, build muscle mass. If you're going to lift things, you have to lift them properly, right? I get Chewy delivered for my dogs and my cats, right? And those boxes weigh 1,000 pounds, right? So you never go and bend at the waist. You always use your legs, right? Because the muscles here are stronger when you lift. Don't hurt your back. And you should always keep your knees bent. That's another thing. And your feet should be hip width apart. So they shouldn't be close together. Okay. So here, center of gravity of our bodies is located right around here, right? And your feet provide the support. So see how he's standing? No. How he's standing? Better, but I feel like his feet are a little too wide, but you get the idea. Okay. And then posture. I'm even guilty of this because I spend days and hours in front of the computer hunched over. You want to try to keep your shoulders back. Like when I walk, I make it a point to try to stand up straight. Okay. That's good posture that I don't have. And body alignment. This is important too for the clients, for patients that are in bed, right? So just imagine this imaginary line right down the center of their body, right? You want to keep their body aligned as much as possible. You don't want them twisted, especially if the person is immobile or has limited mobility, because then what's going to happen is things like contractures, and they are preventable. And contractures are hideous. And it's almost neglect. It is neglect, not almost. If the client can help, let them help. If you're lifting the patient up in the bed, tell them to bend their knees. And when you say 1, 2, 3, you're going to lift to move them up, let them push with their legs so that they help you, whatever they can do. It's good for you to help prevent injury, but it's also good for them for a sense of like, all right, I can do something. I'm not totally helpless because that's, a self-esteem and dignity for the patient, right? And being immobile is a huge problem, and it creates a sequela of other problems, right? This cascade of other things that can happen if someone can't move. Okay. Promote self-care, like I said, prevent complications, use mechanical lifts whenever possible. This says positioning the client, although he's lifting a box, so I think that might be a typo. I'm just going to say positioning. How about that? Sounds better. And see how he's using his legs to lift that box. And that's the right way to do it, right? You don't ever want to bend 90 degrees at the waist. You're going to throw your back out. So it's really important for patients that can't move that you move them, right? Whether it's passive or voluntary. And we're going to talk about that in a minute, right? And there are different positions that we put patients in for different types of procedures too, that you need to know about. So here are some of the different positions and their names. Now, these you need to know. Supine, that is where you're just lying on your back. Prone, face down, lying on your belly. Okay. And we've got Sims, and I'm going to show you all of these because I went online and I got pictures and I downloaded them so you could see what they look like. Okay. So I expect you to know these. This one is not even a thing. We'll get rid of that. Trendelenburg, reverse Trendelenburg, dorsal lithotomy, and lateral. There we go. So those are the positions. Now let's take a look at them, see what they look like. Fowlers. right? They also call it high Fowlers. That's where the patient is sitting straight up. That's a 90-degree angle, right? See, 90 degrees. So if somebody's having a hard time breathing, this is the position you want to get them in because it allows the diaphragm to fully contract and expand. It lets the lungs fill up and, expand. It's just a better position for people to breathe. We also have semi-Fowlers. Semi-Fowlers is about a 45-degree angle. They're kind of relaxed, okay? Lithotomy. All the women in here know that one. Everybody's at least been to the gyno, right? That's always fun. It's feet up in stirrups. Scooch down, scooch down, scooch down. Come on, a little more, a little more, a little more. Come on, how much you want me to scooch down? You want me to fall off the table? Right? You all been there, I'm sure. I know I have. Supine, lying on your back. Prone, lying on your belly. And then this is Trendelenburg, head down. Back in the day, if somebody's blood pressure were precipitously low, we would put the patient in this position. Why? Because it lets the blood rush down to the head and it'll bring the blood pressure up. But it is now, the new research tells us that it's contraindicated to do this, right? So because of other circulatory issues. But there are reasons for Trendelenburg other than blood pressure, resolution. This is reverse Trendelenburg. You see this stuff in the OR, right? When they're doing different types of procedures on patients. Then the tripod, also called the orthopnic, but most people call it the tripod position. You will see people with COPD take this position just naturally. They will lean over something, lean over the bedside table or something to help them breathe, okay? But it's also a position for a lumbar puncture. Okay. So if we need to get a sample of cerebrospinal fluid, the anesthesiologist will come in with a needle and he'll go down in the lower lumbar area, usually L4, L5, and in between the vertebra, take the needle and go into the spinal column and draw out some cerebrospinal fluid. Most often it's used to test for things like spinal meningitis. They're looking for bacteria or virus in the cerebrospinal fluid. And being in that position opens up the vertebra, so it makes it easier for the doctor to get in. If you want to give somebody a suppository or an enema, Sims is the position that you want, okay? They're kind of on their side, but they're kind of on their belly, if you see what I mean. This one leg is propped up on a pillow, so it makes for easy access. Okay. And then we have right lateral recumbent, left lateral recumbent. In other words, on their right side or on their left side. Okay, lying on their side. Get rid of this one, delete. Okay. Positioning for examinations and treatments. So I'm going to pause my recording right now. So let's go to turning and moving clients. How do you do it? Okay. And also preventing deformities. And when they say deformities, they're talking about those contractures where, you see the hands are clenched and you have to literally pry them open to get a washcloth in there so that they don't dig into their own palm. Awful, right? Hand rolls, passive range of motion. If somebody can't move, you have to move them, right? And we'll talk about how to do that. Always repositioning clients and repositioning clients that are immobile every 2 hours at the longest. More frequently if you can, but that's the best. It helps prevent skin breakdown, right? It's the best way to do it. There are different ways to move patients. Log rolling is important if there's a spinal injury because we don't want the head to turn. We want the whole body as if it's a log to one movement, right? And that requires at least 2 people to do it right, right? Again, don't hurt yourself, all right? Okay, range of motion. So when we talk about range of motion, and this is stuff that you need to know, we're talking about the joints, right? And how your joints move. So, can your elbow move like this? Your shoulders, right? You've got full range of motion with your shoulders. Again, passive or active. Active range of motion means the patient is able to do it themselves. Passive range of motion means that you are going to do it for the patient, okay? Here are all the different types of motions that joints can make, okay? And we talked about some of these already, right? Flexion and extension or hyperextension, okay? Listen to what it sounds like. So if I am flexing, right? I pull in, extension, flexion, extension, flexion, extension. For the shoulder, right? If I were going to hyperextend it, right? That means beyond the typical range of motion. Because if you do that, it's a little uncomfortable. I mean, I can do it, but this is the normal range of motion for a shoulder. Dorsiflexion and plantar flexion. When we talk about the anatomical position, and this is important to remember, this is the ventral or frontal aspect, and this is the dorsal, right? Except the foot. So if I'm in the anatomical position and I'm going to try to stand back for this, this is all ventral, except the top of my foot is the dorsal aspect of my foot. That's why it's called the dorsalis pedis, pedal pulse, right? That's the dorsal. The bottom or the sole of your foot is the plantar aspect. Think about plantar fasciitis or plantar warts, right? So when we talk about dorsiflexion, plantar flexion, think about driving your car, right? Doing that kind of a gig. Abduction and adduction, we talked about that. It's easy to remember. If you remember adduction, you add, right, together. Abduction, you bring apart, okay? Circumduction, rotation. Let me highlight these as I'm going. Let me just highlight them all. Okay. Which again, only certain joints, the hip can do it, the shoulder can do it, right? Right. Supination and pronation, right? She remembers, right? We can do this with our wrist, right? Inversion and eversion, I'm not going to worry about those two. I'm going to unhighlight these last four. But the ones that you really need to know are these guys. And when you're doing passive range of motion on a joint, you always use one hand to support the limb above the joint and then the other below the joint. So example, if you're going to be doing passive range of motion on a knee, you want one hand above and one hand below, right? That's not easy to do, right? So you're supporting the joint with flexion and extension, right? Okay. And that's important to know. So remember that. This little machine here is a CPM machine. This one you need to know. Continuous passive motion machine. It's used for when a patient has had a knee surgery, usually arthroscopic or a total knee replacement. Okay. And what does it do? It's this nifty little machine. And the only one that does the settings is the physical therapy or the orthopedic surgeon. They set it for how many degrees they want it to move. The patient, after surgery, they will place the patient's leg into it. Important to know that you put nothing in that part where their leg goes except lamb's wool. There's a little lamb's wool covering that can go there to kind of cushion their leg and their foot. And what this thing does is for 23 out of 24 hours a day, it flexes and extends the knee. Like this. Right? Up in a second, try to get. There you go. Right? Like that. Why? So the knee, the patella, is a synovial joint. What's inside of it? Synovial fluid. Synovial fluid is like a lubricant, okay? What we don't want is we don't want the joint to stiffen up. So if it keeps on moving like that, and this was one of the best inventions since sliced bread, for real. I mean, it's wonderful. It keeps that synovial fluid bathing that joint and allows for a quicker healing process. A couple things to know about the CPM machine that are board questions. Never put it on the floor. Matter of fact, nothing in a hospital or any facility should ever be on the floor or under the bed. It is filthy. Okay, so nothing gets stored on the floor. Nothing should ever be stored on a windowsill. Okay, that's a violation. Okay, they have to be on it 23 out of 24 hours a day, and that 1 hour that they're off is usually when they're going to shower or bathe, right, or whatever. You want to make sure they have medication for pain because it's going to be a little uncomfortable, right, for them to be on that like that. And I think that's about it for the CPM machine, but make sure you know all of that. Never store it on the floor, never on a windowsill, never under the bed. They have to be on it 23 out of 24 hours a day. and it's for post-op after a total knee, right, or some type of knee surgery, okay? Okay. Active range of motion if the client can do it themselves, right? So if they can move themselves, let them do it. Encourage them to do it, right? Isometric exercises are where you're not, I don't know if you remember this from before, right? You're not actually moving. So I can stand here and I can tighten my abdominal muscles or tighten, right? That's isometric. They really do work. They really do work. When you're walking, if you tighten, pull in your stomach and hold it nice and tight, you're going to build some muscle in there. You know, I'm 62. It's hard to get a six pack at this age, but you know, it's not bad for an old lady. But it doesn't prevent contractures, range of motion. There has to be motion in the joints, right? A lot. Should be done minimally twice a day. And I know that it's, you know, I don't usually see it done that frequently, but it should be. Okay, so when you're assisting moving clients, okay, always make sure that there's an order because in this line of work, there has to be a physician's order. If there's a surgical patient, a post-op patient, the surgeon will always write post-op orders, what exactly they want you to do and not do, when the staples should be removed or the sutures, what the activity level is, what the diet is, etc. If you're going to move them, always offer them some pain med. And if it's an oral pain med, it takes 20 to 30 minutes to kick in. So you want to make sure that you're giving them that medication 20 to 30 minutes before you're planning on moving them around so that they can move around. If they're going to physical therapy, medicate them before so that they can participate, right? Okay. Make sure they have their call bell, right? And you always want to increase activity, right? So, and usually that's how the surgeon will write the orders for post-op patients. You know, same thing with diet. NPO, but then they'll start with ice chips if tolerated, move to clear liquids if tolerated, move on to a regular diet, right? Gradually. So helping them out of bed. It's important to let them sit on the edge of the bed and dangle their feet for a little bit to prevent orthostasis. Postural hypotension, okay? So that's where your systolic drops 20 millimeters of mercury or more with a change in position, or your diastolic drops 10 millimeters of mercury or more with a change in position. So if you check the blood pressure while they're lying down and it's 120 over 70, and then when they sit up, it drops to 100 over 60, bam. Now you've got a case of postural hypotension. It's going to make them dizzy when they move from that drop in blood pressure. So you need to move slowly. Do not let them try to like jump out of the bed, which they won't probably, but just in case they try to, don't let them do that because they're going to fall on their face. A gait belt. A gait belt is a nifty little thing that goes around your waist and goes around the client to help them walk, because if you're worried that they're going to fall, okay, if they have an unsteady gait, if they're weak, right, if they're deconditioned. And I will tell you this, for older folks, one day in bed can make them so weak that it takes a week to recover. I mean, that's a lot. Older folks, not me. Other older folks, if you're walking, if you're ambulating a client and they're getting unsteady and they're going to fall, you just ease them to the floor, right? Don't let them bam if you can avoid it, because that's not nice. But see if you can just kind of, and I will use my leg and get them on my knee and ease them down to the floor. Don't try to lift them and hold them up, because you're going to hurt yourself, and don't hurt yourself. Make sure that the clients know, as long as they're awake, alert, and oriented times 3, they should always call for assistance before they get out of the bed, right? They should always use their call bell. Excuse me. Medications and different kinds of disorders can make them dizzy, lightheaded, all of that. So make sure you're telling them to get up slowly. Make sure they have the proper footwear. Make sure they have their hearing aids, their glasses on so they can see. We talked about fall risk evaluation. So the Morse fall scale is one that we use, but there's another one called the tug test. It's the timed up and go. And what we do is we have the client sitting in a chair and we will say to them, all right, I just want you to get up I want you to walk to the edge of the room and then come back and sit back down. And we time them, see how long it takes. And there's a scale for how long it takes and what kind of risk they are. If they're doing this and holding on to furniture, and I know you've seen that before where they can't get up of their own volition, right? They're weak. They're a huge fall risk and they need a device. So just because they don't have one doesn't mean they don't need one. They do need one. If they're using furniture and walls and stuff like that to get around, very dangerous. Bed alarms, again, yes, they use them. Some facilities do, but they are also being looked at now as restraints. So you have to be careful with bed alarms and chair alarms, right? Okay. Is this following statement true or false? If a client is falling, the nurse should let the client grab the nurse around the neck. No, I thought it was pretty easy. I think we unanimously could say that's false, right? Yeah. Yeah, don't let them grab you around the neck if you can avoid it. Other assistive devices, wheelchairs, canes. Let's see, do we have walkers? Yep, walkers. And with walkers, this is important. And don't you see all the time? They're like this with the walker. Lean forward. Where's their center of gravity? Right? They're going to go. They should be upright when they're using a walker. Their arms should have a little bit of a bend, but it shouldn't be like this. That's just an accident waiting to happen is what that is, right? Crutches. A couple things with crutches, and I am actually going to attach to this before I send it to you, crutch gates and crutch safety tips that you need to know for the boards. So we'll start ingraining it in your brains now. When a person's on crutches, they should not bear all of their weight on the axilla. So in other words, the crutches are under their arms. They should not like all their weight on the crutches. No, they should have a small bend in their arm, just a small bend. If they're going up or downstairs, just remember one line: up with the good, down with the bad. Up with the good, down with the bad. In other words, with crutches, going up the steps, you're going to lead with your unaffected leg, your good leg. If you're going down the steps, you're going to lead with the bad leg, the affected leg. Okay? And then there's 3-point gates and 5-point gates, and they look like a rumba dance. It's pretty funny, but I will attach them to this PowerPoint before I send it. Let's see what else we got here. Yeah, and I'm going to include all that, right? Crutch walking gates and all that stuff. All that good stuff. Climbing stairs, I'm going to put that here. I'm just going to say stairs. And I'm going to say up with the good, up, down with the bad. Okay, so you remember that. Here we go. Okay, there you go. They put a picture in, one picture. That was nice, cool, right? There's a picture for you. The knee walker and the hands-free crutch. Don't worry about this. Now, scooters, now that's a whole nother story. The motorized scooters, that's a whole nother story. I see some people know what I'm talking about. They're like, because sometimes they just go buck wild with their scooters. You know what I mean? Now, there are governors on those things. A governor is a thing that you can put on a motor to prevent it from going too fast. Okay? Because they sometimes will, they think they're, here comes speed racer. Sometimes, I mean, a lot of times people, especially in nursing homes, aren't happy. I can't imagine why they wouldn't be. That was sarcasm. Everyone should be laughing at that, but okay. But sometimes it's due to confusion, but sometimes they're just like, I'm just going to run anybody down that's in my way. And that's what's up today. I don't care. Sometimes that's what it is, So be careful with those motorized scooters. They're heavy, right? They are a heavy piece of equipment that really can hurt somebody. So that's all I'm going to say about that. Is the following statement true or false? The client who is allowed to put weight on only one leg must hold up the other leg, bending the knee when using crutches. Picture it, because you're going to have to get used to them using words to describe a gait. So picture it. And if you have to, so I have one good leg and I have, let's say my right leg is my good leg, okay? So here's my bad leg. If I'm using one crutch, right? So you see how I got all the weight on my good leg. Here's the bad leg. Here's the crutch, right? Does that make sense? Yeah, that's the way. This is how we do it. If they're using one crutch, right? So they're bearing their weight, because usually what that means is that that bad leg is either non-weight bearing at all, or it could be maybe minimally partial weight bearing. But at any rate, you want all the weight on the good leg, and then the crutch is going to take the place of the bad leg. Okay? Okay. And if they don't have any upper body strength, you got problems, right? That's why I tell people, while you're young, build a little muscle, right? Then we have lifts or mechanical devices, and there are lots of different kinds of lifts that we can use. So mechanical device that elevates and transfers immobile clients from the bed to the chair, from the chair to the bed, from the bed to the tub, to the shower, whatever, okay? You must have been trained in the lift, okay? It says here, a client lift should be used to move any client who must be lifted. There should not be dead lifts. That is true. Nobody should be deadlifting. In other words, just lifting up a patient. It's dangerous for the nurse and it's dangerous for the patient, okay? But also, you have to make sure that you're trained and that you have assistance and you're using the right type of lift that's appropriate for that patient, okay? So what does that mean? So a sling lift or a Hoyer lift, they can be electric or they can be hydraulic. So in other words, there's some that you plug in, and then there are some that have this like pump thing that you pump, right? Pump them up. And you get the patient in this sling, and then the sling with chains attaches to this arm, and then either electrically or pumping with hydraulics, it'll lift the patient. Hoyer lift should always be two people. Never do it alone. Should never be used on carpet or rug. Only on a smooth floor surface like tile or linoleum or whatever, right? Then there are other types of lifts, sit to stand lifts, easy lift, whatever. They have a bunch of different names, right? And these are lifts that, like this one on the right-hand side, but the patient has to be awake, alert, and oriented. They have to be able to follow directions because they have to be able to hold on. Because if they let go, which I saw once happen, they can really get hurt. Bad. Right, really. So you have to make sure that the patient's appropriate for the type of machine that you want to use. Okay. And then when we talk about how do we classify these patients, and I hate the word classification, it sounds like you're putting them in a box, but so a patient for mobility's sake is either independent, in other words, they can do whatever they can do all alone, a one-person assist, two or more person assist, a total lift, okay? I've never seen transfer in a hospital bed, which is a total lift. So that seems redundant to me. So I'm just going to get rid of it. Bariatric. Bariatric, you should have three people. Bariatric, just for the record, means somebody who is morbidly obese, not just obese, morbidly obese. And there's a difference, right? When I worked in the hospital, ICU called us upstairs for help when I was in the ER because they had literally a almost 600-pound dude. And there were quite a few of us, and we were all young and strong. And we were like, damn, you need a lot of people to lift a patient like that, right? It's very dangerous. So you want to make sure that you've got the appropriate help. Don't hurt yourself, okay? Do not hurt yourself. Back injuries are for life. They don't get better. Sometimes they get a little better, but it's something that you're always going to be dealing with, and it's awful. And then patients who are paralyzed, either partially or completely. So paraplegia means they're paralyzed from the waist down. Quad means four. That means that all four extremities, it's usually paralyzed from the neck down. These are usually due to spinal cord injuries. And where the injury occurs in the spinal cord dictates where the paralysis is. That makes sense, right? So if it's a very high level, then these are the people that have to blow into a straw to make their chair move. right? They don't have anything from here down. They have nothing, no voluntary movement. And then hemiplegia is paralysis, hemi meaning side, one side of the body. This is usually, not always, but usually due to a CVA, a stroke. Okay. Regardless of what you're dealing with, you always have to let them do whatever they can do, right? So if they're a paraplegic, they usually have developed some upper body strength, right? Not always, but usually. So if they can help, let them help, right? Quadriplegia, I mean, they're not going to be able to help. So make sure you have the assistance that you need with staff. And hemiplegia, people that have had a stroke that's significant and that's severe, you want to try to let them do as much as they can safely, right? Safely, because that's, again, like I said earlier, self-esteem and dignity, right? When you have a grown man or a grown woman that's like in their 60s or 70s or 80s and they feel helpless, that is the worst feeling for them to feel, right? You want to hey, listen, you're going to get better. We're going to help you. We're going to help you get better. Come on. If they can tie their shoe, let them tie their shoe, even if it takes 15 minutes. And even if hey, I can tie the shoe so much faster and we can get down to the cafeteria or wherever you go. Just let them do it, right? Try to help them be as independent as possible. It's better for their recovery and it's better for their psyche, for their self-esteem, okay? Then we have things called transfer boards. Okay. That's like a board that we use to get a patient out of a bed, right? Or even in an emergency situation, if somebody's been in a motor vehicle accident or something like that. We have these flat boards, right? That are in case there's some kind of a spinal injury. We want them to be, immobile, not moving. Transfer sled, that's just a bigger transfer board where they can actually use their arms, right, to help move. Lifting sheets, draw sheets, right, we call them. Oh, if you have a patient that's immobile, always have a draw sheet. It just makes life easier to move that patient in the bed. And then, of course, you have stretchers and gurneys and all that good stuff, right? If a client is immobile, move them every 2 hours. Like I said, minimally. And whatever they can assist in doing, let them. Safety devices, medical healing restraint. That's a euphemistic term for a restraint? A restraint's a restraint, no matter what kind of pretty words we put in front of it, right? Okay, so there are times where for the patient's safety, and we did talk about this already, we may need to restrain them. That's got to be our last resort because they're trying to either hurt themselves, hurt other people, staff, other residents, other patients, right? But we already talked about how much monitoring that requires. Every 15 minutes, neurovascular checks. Every 2 hours, you have to release those, those restraints. And a lot of documentation. There is that half bow or quick release or slip knot. It's called a bunch of different things. They all mean the same thing. It's when we go into the lab, I will show you how to do it. So this way, all you have to do is pull the one string, the one end, and it's released, right? And yes, a lap belt or a lap buddy. Isn't that a nice name? It's a lap buddy. It sounds nice. It's still a restraint. Mittens. Sounds like something you put on a little kid. Still a restraint. Right. These are all restraints. Posy jackets. These are all restraints. And this is just going over the same thing again. Let's find an alternative. Let's see. Provide gait training exercise, reorientation. Use a mild chemical agent? I don't think that that's what we should do. And then there are things called wander guards, right? Or wander sensors. They have different names, all for the same thing. It's an electronic device that it can be in a bracelet. It can be in an ankle. It could be somewhere on their body. If they get to a certain point where it looks like they're going to escape from the jail, from the facility, an alarm will go off that will alert everybody like, hey, somebody's breaking out. Right. So anybody have them in their facilities, wander guards? Some yes, some yeah. They were up right there with the bed alarms and the chair alarms in the debate. Is this a restraint? Right. There has to be a way, especially if you're looking at a dementia unit, lockdown unit, to keep these people safe. You don't want them wandering out and getting hit by a car or whatever. So, there are some things that we do still need. And wander guards, I mean, I don't have a problem with wander guards or bed alarms, but there's something called alarm fatigue that I want you guys to know about. Has anyone ever heard of alarm fatigue? Ever heard that term used before? All right, so I'm just going to add one slide in here, and I'm going to talk about alarm fatigue, and then this lecture will be over. If you work in a facility and all day long, all day, do you even hear it anymore? I have seen people sitting at the nurse's station, and it's like Christmas. Ding, 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 beep, beep, ding, ding, phone, ring. It's like a 3-ring circus, and they're just ignoring it. So here's the problem with that. Anybody see the problem with that? What if there's a problem with one of those patients? What if it's not a false alarm? They did so many studies on alarm fatigue. If you are exposed to ringing alarms all day, you will block them out. You won't even hear them anymore, right? And that's bad because especially in a hospital where you have people on ventilators and IVs are running, right? All types of things. So you need to address the alarm that's ringing and hopefully set it up so that it doesn't alarm for no reason. I never understood why we don't fix that, right? Because things shouldn't be beep, beep, ding, ding, beep, beep all day long, right? So just know what alarm fatigue is. So I'm going to put here that it is not hearing alarms when they ring all day. Okay, good enough. Make sure you know that. That is a thing. Okay, you want to make sure that you're going and address it, just like call lights. Where I walk down a hallway in a facility, it's Christmas there too. Light, 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 light. And the nurse is sitting at the desk. And I'm like, really? You can't get up and just, maybe they just want a drink of water. You know, could be something easy. So that's all I have for ergonomics. I believe that's the end. We're not going to talk about pediatrics. We're going to talk about pediatrics when we get to pediatrics. Okay. So don't just disregard that here. Goodbye. See, that was easy. Okay. And then that's all I have for this one. And until next time, peace.